Good evening, everyone. Welcome to the platform of Orthopedic Research and Education Foundation India. Today we have Dr. Dhiren Ganjwala, sir, who is Senior Pediatric Orthopedic Surgeon in Ahmedabad. And I think he not need more introduction on our platform. So over to you, sir,
Yeah.
for today's talk.
Yeah. Can you see the screen?
Yes, sir.
Yeah. Okay. It's a full screen mode, right? Yeah.
Yes,
Okay. So basically, today we are going to discuss two pediatric orthopedic conditions which can come as a question or a short question in the exam. So I will try to give you a basic information which is required for passing this short case. So the first condition which we are going to discuss is the Sprengel shoulder or the Sprengel's deformity. The first question is, what is Sprengel's shoulder? It's a congenital condition in which the scapula is at higher position, and some people call it due to the improper descent of the scapula to its normal position. And so it's called undescended scapula. Like we have undescended testes. Similarly, we have undescended scapula. That's the another name of this condition. So Sprengel shoulder or Sprengel deformity or undescended scapula, it's the same thing. So then the first question, which is we need to understand that what is Sprengel? Is it the name of something or it is the name of surgeon? So the correct question is, who was Sprengel? The Sprengel deformity came from the name of a German surgeon. The full name of him is like the Otto Gerhard Karl Sprengel. And he first described this condition in 1891. So almost like say 130 years before, he described this condition. And remember, the X-ray came in the year 1905. So this was before the X-rays. He described this condition. So then the next question, why does scapula fail to descend? Frankly speaking, we don't have a clarity about that. There are various theories for that. But the important thing is normally scapula descends around the 9th week of gestation. It is at that point the scapula come to its original position and lies in the upper thoracic spine. But why it fails, that we don't know. In small number of patients, there is a omovertebral bar or a fibrous band which connects the spinous process and the scapula, and that probably doesn't allow it to descend. But this omovertebral bone or a fibrous band is not seen in all the patients. Only in a small number of patients we have this condition. So what is the reason why it doesn't descend in other patients, that we don't know. So what is the pathoanatomy of this condition? The scapula is smaller and it's medially rotated, means the superior part of the scapula is rotated medially. The part of above the spinous process, that's a supraspinous part, is not in front of the chest wall, but it is above the chest wall. And so that part is bent forward or tilted forward because there is no support from the chest. In some patients, there is a connection between the vertebra and the scapula, and that's the called omovertebral bar or a band. So this is the CT scan of one patient, where you can see that on the right side. So if you look at the left side of the screen, you can see that there is a bar or a bony bridge between the scapula and the spinous process. The scapula is smaller in size and it's tilted or rotated medially. The part above the spinous process is also tilted or bent forward. So all these important features are seen really well on this CT scan. How do they present? Usually when it's a unilateral deformity, it's asymmetrical because one side is normal, the other side is asymmetrical. And in that case, they present early because it's very evident to the parents that something is wrong on one side. And usually they present early with a appearance problem. Because of the cosmetic problem, they present early in the first year of life. When it's a bilateral, they present late, and it's due to the functional limitation. They are not able to carry out abduction of the shoulder, and that's the reason for the presentation. So either it's a cosmetic or the appearance problem, or it's the functional limitation, which is the reason for presentation. What do we see on examination? The most important sign is there is a restriction of shoulder abduction on the affected site. And this restriction is more when there is a bar, because that bar doesn't allow the scapula to rotate. So shoulder will be able to move at at the glenohumeral joint, but the scapulothoracic movement are restricted. And that movement is completely restricted when there is a bar. So the major restriction is last few degree of abduction is restricted. Just to give you an idea that this is a unilateral condition and there is a left side which is affected. And it's very evident from here that we can see that scapula is at higher level, it's rotated medially, and there is some fullness in the neck. Also, sometimes we feel that the width of the body on both sides are also affected. And here we can see that there is a restriction of abduction, which is very common or which is very evident on the left side. And even up to 90-degree restriction or abduction is not possible. This is another patient, and again, there is a right side involvement. Again, we can see the supraclavicular fullness or fullness on the one side of the neck, and the deformity is very clear. And again, here, if we look at the abduction is markedly restricted. So in some patients, there is a gross restriction of abduction, while in other patients, it's only the few degrees of terminal abduction is restricted. This is one question which may be asked in the ASCII. That's what is a Cavendish classification. This classification basically gives us an idea about why the parents are presenting to us. And it's basically in the 4 grade. The grade 1 is very mild and where the deformity is hardly noticeable. Grade 2 is a mild deformity, which is visible, but it can be easily covered with clothes. So usually 1 and 2, they don't present to us for the management. Only those family where they are very careful about the appearance, they are coming to us. The level 3 is a moderate variety, which is visible and can not be covered with clothes. So as like the cases which we saw, they are either of the type 3 or the grade 3 or grade 4, where we also see a lump in the neck. So all the examples which I showed, they are either of type 3 or type 4. What are the associated conditions? So whenever we have one congenital anomalies, the things which are developing at the same time, they are also abnormal. There is a possibility that they may be also abnormal. The most common problem is there is a Klippel-Feil syndrome or the fusion of cervical vertebrae as shown over here, that this may be associated with Sprengel shoulder. So there is a restriction of the cervical spine movement also. And there is also some renal abnormality, particularly not functional, but the anatomical abnormality. So it's always advisable to go for the sonography of the pelvis so that the renal abnormality can be identified. Coming to the treatment, why we need to treat this condition. The first is like when it comes to treatment, we need to be very clear that there is no role of non-operative treatment. So if parents says that we want to go for a physiotherapy or something else, then we need to clarify that there is no role of non-operative treatment. There is only treatment which is there is a surgical line of treatment. There are three types of surgery described. The first surgery is like we disinsert the muscles from the spinous process. If we want to bring the scapula down, we need to detach either from the scapular side or from the spinous process side. So the first surgery, which is a Woodward surgery, in which there is a disinsertion of the muscles from the spinous process. The second surgery is that we disinsert the muscles from the scapula. That's the second type of surgery, which is called the modified Green's procedure. And the third procedure is enucleation of scapula. Particularly for the first and the second surgery, when we bring down the scapula, along with the scapula, the clavicle is also coming down, and that may cause compression on the brachial plexus. So clavicular osteotomy is also carried out in these, the first or the second options. So let's understand these procedure in slightly more detail. The first procedure is the disinsertion of the muscles from the spinous process, and that's the Woodward procedure. So if we look at the superficial layer, that's the trapezius. So in this procedure, it is released from the spinous process. That's the superficial layer. And in the deeper layer, the muscles which are connecting the spinous process and the medial border of the scapula, they are also disinserted. So usually in this, we use a midline incision and then we disinsert the muscles. After that, we need to bring the scapula down and then we need to tie it at the lower level. There are various ways by doing that. Some people, they use a wire. Some people use a non-explorable suture material. But basically, we need to do something to keep the scapula at a lower position. The Green's procedure or the modified Green's procedure, again, in this case, we detach the muscles from the scapula. And as shown over here, we erase the muscles from the medial border of scapula. The third procedure is called a Dana-Mayer's procedure. Dana-Mayer is basically the hip arthroplasty surgeon, and her major area of interest is a minimally invasive hip surgery. But before few years, she described this Mayer's procedure, and that is very interesting procedure. And the best part of this procedure is that we don't need to release or we need to carry out the clavicular osteotomy. And there is no possibility of nerve compression following this procedure. So let's understand this procedure in slightly more detail. It's also called the enucleation of scapula. So if we are looking from the scapula and all the muscles, they are erased. So to understand that what we do, we first of all carry out the soft tissue release from the medial border. Both supraspinatus and the infraspinatus portion, we release the muscles which are originating from the medial border of scapula. Then we make a cut of the scapula, the vertical cut of the scapula. We need to ensure that the supraclavicular vessels and the nerve which are coming from this area, so the osteotomy remains medial to that, so that they are not affected and we don't hamper the nerve supply to the supraspinatus and infraspinatus muscle. So after this vertical cut, there is a second cut which is transverse. So now the part of the scapula shown over here is separated and that is taken out. We need to ensure that during the surgical, the peroperative, that the abduction should be carried out. And if there is a restriction of abduction, more and more portion of the scapula is removed. As a part of this procedure, the origin of the triceps from the infraglenoid portion, this one, where I'm moving the arrow should also be released. This is technically a bit difficult, but this can be required in some patient so that the restriction of the abduction is taken care of. If omovertebral bar is present, that is also removed. So this is the pre-op picture where we can see that she had a reasonably good range of motion, and she was around 15-year-old when we carry out this surgery. And this is the post-operative range of motion. She had a full range of motion. A lot of patients, they ask us a question, or the surgeons, they ask the question, what happens to the scapula? So when we enucleate the scapula, with the body weight, the glenohumeral joint, it comes to the original position. And then the new scapula is formed because we are carrying out the subperiosteal dissection. So in that periosteum, the new scapula is, and when this scapula is being formed, the child is carrying out the abduction movement so that the new scapula is molded in such a way that it does not restrict the movement. So that was about, in brief, about the Sprengel shoulder. I would like to wait for few questions to answer. So like if you have any questions, please ask those questions at this point before we move on to the second point. You can unmute yourself and then ask questions. Okay, fine. If there are no questions, then we go to the second deformity, which is again a very common case because it can be diagnosed very easily. And that's why this case is also kept in short as a short case. That's the congenital radio-ulnar synostosis. So let us understand in brief about this condition. The points which we are going to discuss: what is radio-ulnar synostosis or synostosis? What are the limitations it causes? And what are the treatment options in the child and in the adult? So these are the 3 points which we are going to discuss. The first question, what is the radio-ulnar synostosis? To understand that, during the intrauterine period, the radius and the ulna, initially it's a one bony end leg, and then later on the cleft develop between the two like this. And this is how the radius and the ulna, they get separated. Now, during this process, which starts from below and it goes upwards, if there is problem in this separation, then part of the bone remain connected like this. Here we can see that the upper radius and ulna, they are connected. We know that we need a separate radius and ulna so that we can carry out supination and pronation. So major problem of this condition is the supination and pronation, they are absent. Whatever is a position of forearm, but we cannot move into pronation, we cannot move into supination. So these are the x-rays where we can see that there is a radio-ulnar synostosis. It's evident both on the lateral and the attempted AP view. Please remember that it's very difficult to take two views, because if we want to take two views, we need to carry out supination and pronation. And when that is not possible, the two proper views are very difficult to achieve. Now, here I would like to focus that what are the problems these children face because of these impairments. So we need to understand that in our activity of daily life, we need supination as well as pronation. There are few activities which require supination. So we are going to see those conditions. So like suppose when we want to wash, or like for the hygiene part, we need supination for cleaning the private parts. When we want to eat with hands, we need supination. When we want to hold a plate like this, as shown in the picture, we need that supination. Look at that, the palm is horizontal and the forearm is fully supinated. If we want to receive something, the lower hand, in that case, we need supination. So and the last is like if we want to catch the ball, again, we need to supine it. So if we summarize that, we need supination for hygiene point of view, to eat with hands, to hold plate, to receive object, and for catching. At the same time, we also need pronation for few activities. The first, when we want to type on a keyboard, we need pronation. Similarly, when we want to use a mouse, we need pronation. When we want to write, we need pronation. And when we want to give something, we need pronation. So we need pronation for working on a computer, for keyboard or a mouse, for writing or for giving objects. So we need both supination and pronation. So now the problem is that these children, they don't have supination or pronation, and their forearm is fixed in one particular position, and that results into the problem. Now the next question, how do they compensate? They don't have a supination and pronation, but body is always trying to compensate. And what are the compensatory mechanisms? Let us understand those mechanisms. So the first compensation is via wrist, because wrist has mainly the flexion extension, ulnar deviation and radial deviation. But in addition to that, it has some ability to carry out supination and pronation. And many times, like we examine the patient from the holding from the hand like this, and at that point, even in a patient with radio-ulnar synostosis, we realize that there is a jog of movement of supination and pronation. And that jog of movement is not from the forearm, but it's from the wrist. So the wrist is the one where it compensates. The major compensation is by shoulder. So when elbow is extended, there are different mechanisms which is working. So let's say that there is a radio-ulnar synostosis, and when we are carrying out activity, and if elbow is extended, then the internal rotation of the shoulder like this will create a pronation, and external rotation at the shoulder will carry out supination. So that's the first way of compensation, and that compensation is by shoulder joint. Now, when elbow is flexed like this, and in that case, the compensation is by adduction. Abduction will cause pronation, and adduction will cause supination. So when elbow is flexed, it's the abduction, adduction which is used for a compensation. And when elbow is extended, the rotation at the shoulder joint are used for compensation. Now the question is, which is easy to compensate, the supination or pronation? I would like the PGs to answer, which is easy to compensate, supination or pronation? Yeah, please
Sir,
answer. Yeah.
Is easy to compensate.
Which one is easy to compensate?
Pronation.
Pronation. Okay, so pronation is easy to compensate. That's right. Because for pronation, we need to carry out shoulder abduction, which is easy. To carry out adduction at the shoulder like this is difficult. So abduction is easy. So pronation is easy to compensate, right? That's the most important point I would like to emphasize. That's the most important point, that pronation is easy to compensate. So most of the patient has a supination deformity. And so when we put this, or like the child has a radio-ulnar synostosis in supination, the deformity is really compensated because the patient can carry out pronation, and for that the shoulder abduction will be able to compensate for the supination deformity. However, the sad thing is that the pronation deformity is difficult to compensate. Synostosis are in pronated position. So what we do, like this, it's in the mid-prone or in pronated position. So here if you can see that it's in a mid-prone position. And this is very difficult to compensate. And so as shown in this figure, like you see that to carry out supination, the child has to adduct the shoulder. And this is extremely difficult. So how can we help them? If we want to help them, then we need to understand that there is no role of non-operative treatment. Like Sprengel shoulder, there is no role of non-operative treatment in these patients. The next question is like when we should consider for surgery. When it's a bilateral case which are in pronation, in that case we need to go for surgery. What we do, that we will see in a minute. So the treatment options are, for our children, first option is the excision of synostosis. And the second is a supination osteotomy. Some Japanese people, they describe excision of synostosis. But remember, when we say that there is a synostosis, we are not able to see the muscles which carry out supination and pronation. They are also missing in these children. So by just excising the synostosis, we may get a passive range of motion, but that does not get converted into the functional improvement. In the adult, we have an option, and that is excision of the proximal radius. That's the option. We will come to that in a minute. So coming to the excision of synostosis, so we consider that if this is the situation, we can excise the synostosis, and in the gap, we can put a membrane, either a silicone membrane or a fascia lata, something like that, so that bone does not unite. The Japanese people, they describe this, that we can separate out this radio-ulnar synostosis. However, only few centers are able to achieve this result. Most of the people who have carried out this technique in India, they say that the results are not good. Patient may get some few degree of passive range of motion, but active range of motion is absent. And the reason is because the muscles which carry out supination, pronation, they are also affected in this condition. When we take X-ray, we are only looking at the bones. We are not looking at the muscles which are carrying out supination and pronation. And because it is absent, we are not able to get movement even after surgery. The most popular surgery is supination osteotomy. So supination osteotomy, what is the rationale of this procedure? And at what age we need to carry out this procedure? And in which position we keep the arm after surgery? And what are the results? So the rationale is, we need to make it very clear to the family that by this surgery, we are not going to restore supination or pronation. What we are doing by this procedure is, we are rotating the position of forearm so that it's in a 30 to 40 degree supinated position. Because when it is in supination, we can carry out the pronation with the help of shoulder movement. That's why we are keeping it in a supination. So basically what we are doing is by separating the radius and ulna from proximal and distal part, we are rotating them in relation with the proximal part. So we are basically derotating the forearm. And then we fix the forearm in supinated position. When I say supination, we don't keep it in a full supination. We keep it in 30 to 40 degree of supination. So basically the aim of this surgery is that it facilitates compensation. What is the appropriate age? Usually 4 to 9 years is the age where we carry out this surgery. What is the position of forearm? If there are two hands which are affected, then the dominant hand should be kept in 20 to 30 degree pronation. Here, different surgeons have a different belief. My understanding is if one hand is in pronation, we need to keep that hand in pronation because we need pronation for some of the activity. So the dominant hand is kept in 20 to 30 degree of pronation, and non-dominant hand is rotated to 20 to 30 degree of supination. So if it's a bilateral condition, one hand is in pronation, we don't need to operate that. Only the non-dominant hand should be derotated and should be kept in 20 to 30 degree of supination. What are the results? So let's see this video so we get the idea. The right one is the affected, and we can see that the child is not able to carry out supination. Here, the osteotomy of the radius was carried out and the rotation was achieved. Some people, they just give plasters. Some people use intramedullary nail. And particularly for a slightly older child, we need to fix it with the plate so that whatever derotation we carry out is not lost. If we rely only on plaster, there is a possibility that the some rotation which we achieved is lost. So when we use plate, the forearm is fixed in a particular position which we have targeted or which we have achieved at the time of surgery. And this is a post-op picture that shows that the child is able to carry out good range of motion. The procedure for the adult, we can definitely carry out this procedure for the adult, but there is a technique described by an orthopedic surgeon from Delhi, and they suggested that if we carry out the complete excision of the proximal radius, like if this is a radio-ulnar synostosis, we can take out the whole proximal radius because now it's an adult and there is no possibility of valgus angulation at the elbow because the ulnar collateral ligament are strong enough in this age. So we can excise the complete proximal radius, including the part of the synostosis. And then we cover this proximal radius or the remaining radius, the end of the radius, with a fascial arm. So that again, the cross union does not develop between the radius and ulna. So this is the Dr. Gaurav Garg and the Som Gupta. They presented this work in the SICOT journal. And basically, what are the results? This is one of the example from their paper. It is not my case, it's from their paper, where we can see that the complete proximal radius is excised. And the results are Remember that before surgery, there is no supination pronation movement. But after surgery, the active supination was 15 degree and active pronation was 60 degree. So substantial 75-degree range of motion was achieved with this surgery. The passive range of motion was slightly more than the active range of motion. And as shown over here, it is 25-degree supination to 65-degree pronation. So 80-degree of passive range of motion. So I would like to conclude my talk with the important message that if it's a bilateral case in pronation, it leads to impairment. If one hand is in pronation, one hand is supination, then child will not have any problem because those activities which require pronation, for that the child will use pronated hand. And those activities which require supination, the child would use the other hand. But when both sides are in pronation, there is a problem. Excision doesn't give a good result in children. Osteotomy is basically a repositioning osteotomy and it does not restore movements. That has to be conveyed to the family that we are facilitating compensation. We are not doing surgery for gaining range of motion. So as I said, this is to facilitate compensation. And in adult, the excision is an option. We cannot carry out this procedure in children because if we carry out the complete excision of the proximal radius, then it may lead to instability in the children. So with that, I would like to conclude my talk and I would be happy to answer your questions. Thank you.
Thank you very much, sir. It was quite informative. So we have one question from Dr. Pratyush that you told that after plaster, some range of motion missed. So that is a doubt.
I didn't get Pratyush. Can you ask the
Unmute
question?
and ask, yeah.
Yeah, unmute yourself, and I would like to understand your question.
Sir, you told that after a plaster,
Yes.
some range of motion is missed in supination and pronation. Sir, how it is?
So you are talking of the adult or the pediatric one?
Pediatric, sir. Pediatric one.
Pediatric, okay. And that you are talking of the radio-ulnar synostosis.
Yes, sir. Radio-ulnar synostosis. Sir.
Okay, yeah. So the second part, see, basically when we give a plaster, and if we are relying only on plaster for maintaining the position, usually this osteotomy takes 2 to 3 months for union. So we need to keep plaster for a longer period. I have seen some example where the resident, they are under the impression that it's a small boy and 6 weeks plaster is adequate. And in that case, if you remove the plaster early, the position which you have kept at the time of surgery, that's basically 20 to 30 degree of supination. That position will be lost if you remove the plaster early. Again, we are not aiming for range of motion. We are just changing the position of forearm so that instead of pronation, it is in 20 to 30 degree of supination. But early removal of plaster may cause a derotation of the radius and we may lose whatever we have desired position, that will be lost. That's what I was trying to convey. Is
So
it
the
clear?
range of motion, yeah. The range of motion may be same, sir, but it is not supinated. It is more
Yes,
pronated in that case.
exactly. You don't expect any range of motion after this osteotomy. This is just to facilitate the compensation. And so we are putting it in the 20 to 30 degree of supination.
So, in that we have told that to place that one membrane like thing or silicon something or fat. So how that surgery should be performed, sir? Because even in elbows, one like some degenerative changes in the articular cartilage in that one, Baxi has described that to put fat so that the range of motion we can get. So how this surgery usually performed, because our newer generation have not seen this.
Okay,
So
so basically, we need to take a fascia lata from the thigh, and then we take a strip of, or like the piece of 3 to 4 centimeter thick piece of fascia lata, and then we cover it with um, the radius which we have excised. The raw end of the radius is covered with that fascia lata. If you have seen the X-ray very carefully, they have shown few holes. So they have used a hole in the bones through which they on which they fix the fascia lata. So that is how they covered the bone, raw area, so that the bone-to-bone contact doesn't occur and the bone-to-bone growth does not develop. That's the basically aim. So in India, basically silicone membrane is not easily available. So the easiest thing is to take a fascia lata and cover both the raw surface, the radio-ulnar synostosis part which we have excised, and the proximal stump of the remaining radius. Both are covered with fascia lata.
so sir, in that case, what is the protocol? We should start the range of motion as soon as pain subsides, or
So initially, we need to give plasters for few days, and after that, we start passive range of motion first, followed by active range of motion. And again, we need to remember that the primary supinators which we have, or the pronators which we have, they are actually missing in this patient. So whatever we are getting is basically by the secondary supinator and the pronators which are actually producing this movement. Because when
so
you
so
when
the
you
passive will be more, sir. Yeah.
yeah,
Yes.
passive will be more, definitely passive will be more, active will be definitely restricted. Yes.
Okay, so you was telling. Please continue that sentence, sir. We have
Yeah,
interrupted
so
you.
basically, like say, when we take out the proximal radius, the whole supinator is detached. So basically, there is no active supinator. So what? And again, the attachment of the biceps and the brachialis, they are also detached. So whatever we are gaining is basically the secondary supinators, which is going to give us this movement. For pronation, we have a pronatus quadratus which is intact, and that may be working. But for supination, I don't know, there is any no muscles which is remaining, and that's the reason like the supination is very less compared to the pronation. If you have seen that graph, the supination is hardly few degrees.
Yes. And so, uh, how much of the proximal radius is safe to excise?
Yeah, in this study, they have taken out like 3 to 4 centimeter of proximal radius. Because see, we need to excise the part where the synostosis is. That much part anyway we have to excise. So that is usually 3 to 4 centimeter of proximal radius that is excised.
So, sir, that part which is having insertion of pronated teres is also intact
Pronator
in
teres
that.
is slightly in the mid radius, so that may not be lost. But the supinator is completely taken out because the whole supinator is from that area and there is no
So,
muscle left, or like there is no bone left. So exactly. So, and again, the attachment to the radial tuberosity, the biceps is attached to the radial tuberosity. That part is also completely excised. So in that case, there is no supinator muscle is left. So whatever few degrees of supination they have shown in the article, I am still wondering from where they are getting this supination. But this is very well documented, and that's really a good series, and that's again from the India. So I really emphasize that this is something we can try in adult patient.
yes. So, one question from that Sprengel shoulder deformity
Yes.
that you told, sir, that is type 3 and type 4 is quite obvious and usually it presents. But in exams, sir, few of us getting a winging of a scapula case. In that one, we should think of that type 1, type 2, maybe the in that one. Or
Winging of scapula is not because of this.
yes,
So
sir.
that's
True,
a
sir.
completely different condition. That's, I think, the serratus anterior palsy, which leads to winging of the scapula. So this is different. But yes, in a differential diagnosis, we should always think this as a possibility.
Yes.
Yeah.
Because that medial winging and lateral winging, they classified that in, so that sometimes it is the medial border is prominent, sometimes it is lateral border is prominent. That is little complicated in that one, sir. This one we can keep it as differential diagnosis
As
if
a,
we are
absolutely,
present.
yes. Yeah, yeah.
Okay, sir. And what is the management of that one, sir? Like, if it is type 3 and type 4, then only we need to manage.
Okay, that's a very
Otherwise,
good question. And like, frankly speaking, I was not aware about this Cavendish classification. The reason is because in the practice, this classification doesn't help at all in decision making. When parents come to us with a clear request that we want to do something for this problem, we have to operate. So
yes,
in the decision making, the Cavendish classification is not really playing any important role. It all depends on the family. If they want surgery, yes, we have to offer surgery.
and
So actually,
in
I was not aware about this classification. When I sent it for the review with Professor Hitesh Shah from Manipal, he said that, Dhiren, you need to add this classification because that's the classification which is asked many a times in the exams. That's why I added.
yes, sir.
But frankly, I
Even
have not used it in my practice.
yes, even sir for congenital cinders, that one, sir, in the
Which
forearm.
yeah.
Uh, in that one also they have vast classification for that once in DNB. So I'm not sure. Usually, I think that one is one bonies and fibrous. I think someone and a part of the bone, how much it is involved. That one in that way it was classified. Whatever I don't know the I didn't remember the name, but one classification is there.
But again, fine. See, when it comes to the decision making is very clear that
Yeah.
if child is impaired, then we need to carry out a derotation osteotomy.
Yes.
Whatever is the length of the synostosis, that doesn't make any difference because we are not going to excise synostosis.
Yes. Sir. I think if some more question we'll have, then we'll discuss. We'll go ahead with that one.
Let's see, there is
Anyone
one.
have any confusion? So you can ask right now, Adish. I think it is very clear for all of them.
And actually, I have tried to give only the practical information, not
Yeah.
really everything related to this, because this will be the short case. And the points which we discuss, if the candidate knows this much, then I'm sure that he's going to pass with a good mark.
True, sir. Because it is quite difficult to understand that one, and with this diagrammatic presentation, I think it is very much clear for us. I think we also have learned a lot. So thank you very much, sir.
Yeah,
And
thank you.
yeah, we'll have the next class is about, sir. I mentioned something.
Yeah, so whichever is like remaining, we can cover the torticollis part also in the subsequent thing.
Yeah.
And whichever another case, short case, which is asked from the pediatric orthopedic, we will cover that. So we will club the torticollis and something else in the next lecture.
Yes.
Yeah.
So thank you
Thank
very
you.
much, sir. It's great, sir. Thank
Bye.
you, sir.
Thank you, sir.